Assalamualaikum, greetings from Turkey. And I will try to share you some measurements of distal coronary perforation. The incidence of coronary perforation is reported to be low, but it is a life-threatening situation. You know the classification of LS, type 1, type 2, type 3, and type. As Mahmud has presented just now, there are several perforation types: vein vessel perforation, distal wire perforation, collateral perforation, epicardial or septal. Now, today we will give some examples for distal wire perforation. Most of the coronary artery perforations are recognized at the time of coronary angiography. That early recognition of the case is important for acute management. However, in subtle cases, it may be unrecognized, and during follow-up in wards or in coronary care unit, acute onset of shortness of breath, hypotension, and unexplained new tachycardia may be related with this case, and it may be recognized later with diagnosis of pericardial effusion on echocardiography. What can we do? The prevention is the most important point, especially when we deal with hydrophilic wires, especially with CTO procedures. Low pressure, prolonged proximal balloon inflation is the first step usually, but at the same time we should give IV fluid and inotropes. If necessary, intra-aortic balloon pump may be in some situations. Anticoagulation should be reversed just after taking out the catheter, otherwise we will have a catheter-induced thrombosis maybe. Platelet transfusion can be of some benefit, especially in patients who have received GP2B antagonist. Urgent pericardiocentesis is important for hemodynamic stability. This brachialis shame, inflation of balloon, intravenous periods, pericardiocentesis, and notification of the surgeons is important for urgent management in some cases. For distal perforations, what we do have extrally, embolization of fat coils and cover stent for occlusion of the perforated branch in some cases. That's the same presentation. Cover stents has the disadvantage of thrombogenicity. They may have higher restenotic rates. Coils are especially useful for distal coronary artery perforations. Microspheres also useful, but there are some different types. Some are used with 0.14 wires, and some are inconvenient with 0.13 wires. We should know about that. Autologous blood clots may be useful in some cases. Thrombin injection, autologous subcutaneous fat injection, and some cases wireframe embolization may be used. If you do not have coils or microspheres in your lab, you can cut some tip of wires and send them like coils. Today I will show you balloon embolization method especially. It was first described as perforation of a cut balloon with another balloon. That is there is this advantage of embolization of that balloon. So when you do that, especially you should use extra support wires for stability of the wires. Otherwise, maybe we embolize the cut balloon to another place. This is another method described by one of our colleagues in Turkey, Ağaç and et al. They cut the balloon, then with the introducer cut part of introducer, they push the balloon towards the tip of the shaft. Then they introduced it to an unexpanded stent. When the stent is opened, a closed loop is occurred, and that may be used for coronary perforations or for fistula. Now here our case, a 61-year-old patient with CTO management. Can you play the other videos also? Okay. First, the lesion was crossed with field RXD, and it was then looped with pilot 50. We supposed that we are in the LAD, but it was not the case. We have balloon dilatations. Play the video, please. You see that the wire is in septal branch instead of LAD. Therefore, we have a double lumen fine-dior microcatheter and inserted an extra support wire towards the LAD. We have our balloon pedilatations for CTO segments. First of all, due to CTO, we couldn't observe distal perforation at the beginning, but when we open the artery, we see that there is a distal perforation in the septal branch that we first entered. Hemodynamic stability, hemodynamic was stable at that time, so we continued with LED stenting. We had our disimplantations to LED. We see that distal extravasation was persistent, therefore we have prolonged balloon dilatations just at the level of that septal branch for 10 to 15 minutes. Then we see that extravasation was disappeared, and we continue LED stenting to proximal and osteum. I couldn't press. The next slide, please. And we have post-dilatation with NC balloons. Then we have the final images. There is no extravasation at that time. But at the second hour of the coronary, intensive coronary follow-up, the patient developed hypertension. Blood pressure was required with IV fillet and appropriate position and abdomen infusion. We checked with echocardiogram, we see that, and remarkable amount of pericardial effusion. We immediately have pericardial synthesis for that. Next slide, please. So what can we do now? We have tried prolonged balloon dilatation before, but again, now our first approach will be prolonged balloon dilatation again. We can use graft stents to main vessel, but there are some advantages for that. We can use coil or microsphere, but we didn't have those materials in our lab at that time. We can use fat embolization from groin of the patient. Some autologous blood clots may be embolized also. Wire fragments may be embolized. And we have pericardial synthesis, and after that the hemodynamic was stable. We have prolonged ballodilatations for 15 minutes, but still there was extravasation in the septal artery. Therefore, we crossed the septal artery within the stent with a whisper wire, and we have balloon dilatation within the vessel at its proximity. But there was still extravasation ongoing, and we tried fat embolization through microcatheter. You know, gravity of the fat is lower than water. Therefore, when you face down the entry of the microcatheter and after filling of the microcatheter with fluid, they go towards distal. But that is what that was not satisfactory in our case. Thereafter, what we have done is that we cut a balloon that we used in the septal branch, and I will show the video for that, and embolized it. We cut balloon at the middle, we detach it and reattach. There is some attraction between the two units, and they move just like a one unit. When we reach the target site, we retrieve the wire a little back, and the distal cut part of the balloon drops, and it opens like a parachute or umbrella, and distal coronary perforation is managed with that. You see, before there is a distal perforation, and after the balloon embolization, there is no problem. So, in short, wire-related coronary artery extravasation may be a fatal rare complication of PSI. Prevention is the most important point. Be curious with wire tip, especially that of hydrophilic wires. However, if it occurs, it should be promptly managed. Coils and microspheres are required to be present in the cath lab. However, this may not be possible in some conditions. So, with homemade maneuvers, we can embolize thrombin, fat, or balloon in distal coronary perforation cases. Thank you very much for your patience.
Thank you so much, Dr. Gunez, for your wonderful presentation. Now, because the live case is ready, so we have now to go to China, Nanjing University, and Professor Chen is also here. So can we be connected to the lab in China, please? Hello, good morning, good afternoon. Hi, Dr. Zhang, how are you? I'm Dr. Raza, and we are ready to see your case. I'm sorry we're just 10 minutes late, but now we go on. And we have a panel of experts from United States, United Kingdom, Turkey, and Pakistan. So I would also invite Professor Chen to come here and assist me in moderation. Can you please go ahead and tell us the history of the patient, please? Thank you.
Sure. I'm Dr. Jun-Jie Zhang from Nanjing First Hospital. On behalf of Professor Shaoliang Chen, I really appreciate your kind invitation participate Pakistan Live 2022. So Dr. Raza. So first, let me introduce my team. In my right hand, Dr. Ge Zhen and Dr. Li Xiaobo will assist me perform the case. And also our technician in chief, Mr. Pan Tao, will interpret the IVUS. So first, let Dr. Ge Zhen introduce the case information. Please, Dr. Ge Zhen.
Okay. PPT, please. Okay. Can you see my slides?
No, not yet. Please switch it to slides.
Okay.
Can you see the slides?
No, not yet.
Okay.
If still no slides,
please.
you can brief. Okay, now we can see.
Okay. Okay. Ladies and gentlemen, I'm honored to here introduce the case presentation. This is the 38-year-old male because the recurrent chest pain for 3 weeks admitted to our hospital. 3 weeks ago, the patient had the non-STEMI and treated with the medication in the other hospital because the recurrent chest pain and then transferred to our hospital. The patient had the diabetes, hypertension, and after admission to our hospital, and laboratory tests show the cardiac mark and activity, and the EGFR is nearly normal, and BNP is normal, and the UCG shows ejection fraction 41%, and the inferior wall hypokinesis, and ECG shows inferior wall and myocardial infarction. And clinical diagnosis is unstable angina and recent inferior myocardial infarction. And we did the angiography for this patient, and this is the baseline angiography, and we can see the RCA, the distal RCA, and severe stenosis, and the lesion is tended to the proximal PAO. And this left coronary angiogram, we can see the distal left main and bifurcation lesion involves the distal left main and involves the ostium circumflex and LAD. And we also can see the lesion from the proximal LAD and to the middle LAD. From the spider view, we can see the bifurcation lesion very clearly, and the lesion involved ostium circumflex, also the OM. So next. And we did the PCR for this patient and use 2 drug-eluting stent and with the 3.5 non-compliant balloon pulse dilation. We also stratified this patient and calculate the syntax score 35 and the syntax 2 score for PCI 33 and predict 4 years mortality 10%. And for the CABG and 34 and predict 4 years mortality 10% also. And we calculate the NUST score and greater than 19. That means the patient is a high-risk patient. And according to the definition criteria, is the distal left main bifurcation and meet the 1 major criteria and 4 minor criteria. That means complex bifurcation lesions. Also, next.
Thank you for your introduction. So actually from baseline angiography, it looks like a trifurcation distal left main. So also we have a strong panelist. So can I have some comments from panelists?
Hey Jun-Jie, this is Tanvir. How are you? You okay?
Yeah, great to meet you, Tanvir.
Okay. So the interesting lesion, very classic of Nanjing, a distal left main bifurcation stenosis. So we already defined lesion complexity. So based on the algorithm we published, this is a complex lesion and you're going to do a 2-stent technique. The issue is the origin of the marginal, whether you're going to leave it alone as part of your strategy or do some modification of the plaque of the ostium before you do a 2-stent strategy. I didn't see the amount of calcium, so obviously you're going to do some IVUS imaging of both branches, and if it's calcium, maybe we'll do some plaque modification. Xiaoleng just told me you may have a shockwave type of balloon in China now, so if it requires plaque modification, you could do IVL if needed before you do your 2-stent strategy.
Pilar.
Yeah, thank you very much, Tanvir, for your comment.
Well,
So
I'd like to see him what he does, and then I'll talk about it.
Right, very nice case, very educative. It's a trifurcation anatomy, complex lesion. And one thing which I see is the OM branches at the right angle, so hopefully it doesn't look to be osteal disease. So probably one suggestion is that we'll do just 3 wires, but maybe 1 or 2 stents. Thank you.
Thank you. Angiography, now the angiography is zoomed in, so clearly there is mild to moderate calcification at the proximal circumflex. So Jun-Jie, do you plan to pre-dilate circumflex and then check IVUS first?
Yeah, Prof. Actually, we didn't do the predilation. According to the strategy pre-decision, we performed the IVUS evaluate. So let me let Dr. Pan introduce the baseline IVUS from the LAD, OM, and the circumflex. So please, Pan introduce the IVUS.
Yes.
Okay. Hello, everyone. Can you see the IVUS imaging?
Yes.
Okay. Let me show the IVUS imaging. The first round, we check IVUS from the distal LAD to left main. And here, the distal LAD is normal. And here, we can see the muscle bridge. Then go back, we can see the septal, we are showing LAD. And then here, this is the distal septal. And the vessel, here the vessel diameter is about 3.0 millimeter. Then go back. And here we can see the attenuation plaque. And then here we can see calcified plaque. Then go back. And here, this point is the minimum lumen area of LAD, and here the area is just 2.7 millimeters square. But the plaque burden is more than 77%. Then pull back. And here we will see the diagonal 1 joining LAD, and here we can see calcified plaque. Then pull back. This is the proximal LAD. And the proximal LAD vessel diameter is more than 3.6. Then pull back. Here, this is the ostium LAD. And here we can see the circumflex will join LAD. And then here, the ostium LAD area is about 5.6 millimeters square. The plaque burden is about 64%. Then pull back. This is a POC, and this is the distal left main. The distal left main area is just 3.2 millimeters square. But the plaque burden is more than 86%. And then here, this is the distal left main. The calcified plaque angle is about 220. Then pull back. This is the left main body. And the vessel diameter is about 5.0 millimeter. Then pull back. This is the ostium left main. The whole left main vessel is not normal. We measure the narrowness from the distal reference to diagonal 1 is 21 millimeter.
Thank you. Can you just...
The narrowness,
yeah, please go
okay,
ahead.
the narrowness from the distal reference to ostium LAD is 41 millimeter. And the whole narrowness from the distal reference to ostium left main is about 58 millimeter. The second round, we check IVUS from the OM1 to left main. And the OM1, the distal vessel is normal. The vessel diameter about 3.0 millimeter. Then pull back, we can see eccentric plaque. Then pull back. And here we can see the calcified plaque. And this is the minimum lumen area of OM1. The area is just 2.0 millimeters square. Plaque burden is more than 77%. Then pull back. We can see the circumflex join OM. Here, this is the bifurcation of OM and the circumflex. The area is just 2.2 millimeters square, and the plaque burden is more than 71%. Then pull back. This is the ostium circumflex. The ostium circumflex area is just 1.7 millimeters square. The plaque burden is more than 88%. The third one, we check IVUS from the distal circumflex to left main. And the distal circumflex vessel is normal. The vessel diameter is about 2.8 millimeter.
And pull back, and we can see this is the bifurcation of circumflex and the OM1. and the ostium circumflex is 3.0 millimeter square. Plaque burden is just 60%. Then global back, this is the proximal circumflex. And the whole lightness from the distal reference to ostium circumflex is just 6 millimeter. Okay, this is the baseline IVUS imaging.
Yeah, thank you. We have seen the IVUS findings now. Can we just request quick comments from the experts? What do they change the strategy or what to go for?
No, I think what I suggested, one thing that Xiaoling and Jun-Jie taught me is to image everyone, so I image everybody now in my complex PCI cases. So the strategy will not change. You'll have to have some plaque modification strategy, either with a high pressure non-compliant balloon or if you have IVL, do that at distal left main. But certainly you'll have to pre-dilate these lesions before you do and probably end up with a decay crush here.
We have a huge amount of calcification, so we should do some kind of debulking. It's a must, and we must prepare a shockwave lithoplasty balloon. In fact, it's a challenging case, I think, and we have 2 bifurcations, so we must have all the materials ready before beginning this case.
Since we have limited time and we have to see the whole case, that will be more interesting. If there is any hot burning question? No. All right, so we go on. Sorry.
Oh, thank you. Jun-Jie from IVUS, I think a distal landing zone of first distal could be just beyond the diagonal if you don't want to deploy 2 stent for AD. Nothing that causes second bifurcation involves circumflex and obtuse marginal. IVUS confirmed 2 calcified nodules localized as a proximal AD and circumflex. So, what's your strategy is?
Okay, Prof. Zhang and Dr. Ada, thank you very much, my distinguished panelists, recommendation for this case. So let me introduce what we have done today. So from the first picture, actually before we do the left main, we do the right coronary angiogram. You can see the previous stent was patent. And also it's definitely a dominant RCA next. This is the AP code. We still show the previous 2 stents in the distal RCA is a patent. Next. So then we switch to the left coronary. So today's PCI, we transform the right radial approach with the 7 French EBU 3.5 guiding cassette to engage the left main. This is the AP caudal view. You can see there is a severe calcification at the distal left main extended to proximal AID. And from this view, you cannot distinguish the ostimal circumflex. Next. So this is IO caudal view. You also can see the first OM margin branch is larger than distal circumflex. Next. This is the RAO creative view. You can see clearly from the distal LAD to the proximal and the middle LAD. Actually, from the angio, it's longer diffuse lesions from the left main to the middle LAD. And also the very big diagonal, the ostimal diagonal is normal. Next. This is an AP creative view. You also can see a severe calcification from the distal left main to the proximal to middle LAD. Next. This is aerial cranial view, shows clearly the distal left main eccentric plaque, and also involves the ostimal circumflex. Next. So this is a spider view. For distal left main, I think the traditional spider view can show the distal left main 2 bifurcation lesions. And considering the OM is a large branch than the distal circumflex. So from this view, we consider the circumflex to OM as a side branch for the stem deployment. Next. So this is, we perform the IVUS evaluation sequentially from the LAD, OM, and the distal SIR. So just now, Dr. Panto has introduced the IVUS baseline information. So from the IVUS baseline information, next. Considering the distal left main calcification is significant, but the ERK is less than 217. So from this view, we think NC balloon predilation can do the good prepare for the calcified lesion. So firstly, we use a 2.5 balloon to do the predilation.
Jun-Jie, would you have considered ROTA if you didn't have shockwave for the distal left main? That's my first question. Secondly, did you check the EDP because the EF was low? Would you consider any support or not?
Yeah, actually, considering IV shockwave is also a very good option for this kind of calcification. Considering the EF is low, and also considering from the IVUS imaging, the calci-arc is less than 217. So we think use the NC balloon predilation when we'll do the good preparation for these calcified lesions. So we didn't want to do the shockwave for this case. Consider it's a low LVEF case.
Yeah, another question is that patient LVEF is only 41%. Is IBP or impeller standby?
Actually, we just puncture the left side femoral, but at this time, I think the patient is stable. We didn't insert the IBP, only standby.
Okay, go ahead.
Okay, so according to the IVUS evaluator, actually from the proximal to mid LAD is diffused lesions, and also the plaque burden is more than 55. So we decided to put one stent from the middle LAD to the proximal. So according to the IVUS evaluation, the first stent size is 2.75 by 33, 5 Hawk stent. Yeah, next. So this is stent position according to the angio and the IVUS. Next. And we deploy the 2.5 by 33, 5 Hawk stent at 12 atmosphere. Next. Then this is an angiogram. Yeah, we after stent deployment. Then from the angio, I think there is stent on the expansion. So next we use a 3O balloon to do the post dilation at 20 atmosphere. Next. Next. Okay, so this is what we have done now. So according to our discussion just now, considering it's a distal left main complex bifurcation lesions, our decision is to perform IVUS guidance with a decay crush technique for this particular case. And also considering the OM branch is larger than distal circumflex, we consider the OM as a side branch. So that's my strategy. So if your permission, I would like to do the case with the decay crush step by step. And also the father of decay crush technique is on the floor. So Professor Zhang, you can guide us to perform this case.
Yeah, panelists agreed with the use of decay crush. So can you show us step by step about the decay crush?
Okay, so we haven't predilation. So I would like to predilation with a 2.5 balloon of the circumflex.
So now the second one insert or in obtuse marginal?
Yeah, there is a 2 wire. One is in OM, one is in distal cert.
Okay. So is there any concern about the acute occlusion of circumflex after predilating obtuse marginal?
Yeah, there will be the possible. So that's why I put a wire to protect the distal cert. And from the IVUS, actually the lesion at the distal cert is very focused. So I think the risk will be low, and also the angle is quite large. So I would only use a wire to protect the circumflex. 6. So I will use a 2.5 balloon dilate the proximal cert to the OM margin. Yeah, next. Please give me a 2.75 by 23 scans.
Do you think a spider view is the best view to separate the circumflex from obtuse marginal?
Yeah, I fully agree with. So please go to the spider view.
Okay. So now you have predilated obtuse marginal. Is that correct?
Yeah, I have pre-dilated obtuse marginal. Then I will do a picture at the spider view. Test, please, small test. Okay, let's do a picture. Okay, ready? Yes.
Okay.
Yeah, this is the angiogram after pre-dilation.
Yeah, after pre-dilation, the blood flow is fine inside as well in the obtuse marginal. So next will be the first stent, obtuse marginal with short protrusion into left main, right? So what's the size of side branch stent? 2.75?
Yeah. According to the IVUS evaluation, so 2.75 by 23 stent were deployed from the OM to the circumflex and the minimal protruding into the left main. At the same time, I will put a 3.5 NC balloon at the distal left main, which will be used to crush the circumflex stent.
Okay.
Okay. So 3.5 balloon.
So this is a 2.75 stent, right? You cannot see clearly.
Yeah.
Okay.
Yeah. It's 2.75 stent in circumflex. I think there is a one chop, so I would like to put out to the circumflex wire.
So what's the guiding cassette?
It's a IVUS 3.5 7 French guiding cassette.
Okay. So the mammoth balloon is 3.35 millimeter.
Mammoth balloon is 3.5, Prof.
Okay. I think you can a little bit distal.
Are you happy with the position? It's a minimal protruding maybe 3 millimeter. Do you need another view to check the distal stent location? AP caudal. 正为主，没有信号了。
Okay, we can hear you very
There is
clearly.
no signal. We lose the signal.
Yeah, can you hear us? Can you hear me?
Jun-Jie, why didn't you choose to go into the native circ rather than the OM? Was that because of the angle?
Yeah, now the
这是2.75啊，兄弟们。2.75对，是。
yeah now no connection, no audio. Jun-Jie, can you hear me?
Yeah, we just lost the signal. Now I can hear you clearly.
Okay, so you have deployed the circumflex stent.
Yeah, up. And I pull out a little the stent balloon to do the post dilation and also to do the side branch optimization with a higher pressure to 12.
So this is stent balloon.
Yes.
Yeah, so recently, we have slightly modified the decay quash.
Yes.
Immediately after standing side branch, we can use a stent balloon or another NC balloon to optimize side branch. Yeah, to try to minimize the gap between stent and the carina.
So, Prof, I would like to use the 3O NC balloon to do the side branch optimization, considering the ostimal circumflex is a large vessel.
Yeah, I think so. According to the IVUS, the proximal circumflex looks like 3.5. Is that correct? 3.5.
Yes.
So they use the 2.75 stent according to the distal diameter of obtuse marginal, which could be very emphasized for proximal circ. So this is why.
So I would like to use the 3.25 short NC balloon to do the side branch ostimal optimization.
Yeah. So I think your live transmission is very important to help us to understand how to do decay quash, particularly for trifurcation lesion.
Now I use a 3.25 NC balloon to do the post dilation of ostimal circumflex. Please go to the spider view. So at this time, we will be very cautious to avoid the 3.25 extending into the OM margin. Test, please. Okay, we didn't pause.
Yeah,
okay.
I think you can put the LID balloon as distal as possible.
Oh, okay. Thank you very much for your suggestion.
Yes, perfect.
It's safe. Yeah, thank you, Prof. Small test, please. Okay, good position. Do you have just 1 minute?
Yeah,
Let's take
very
a
good,
picture.
very good position for sunflex NC balloon.
Okay,
But blood flow in sunflex looks good.
looks good. Up.
Yeah, no more
Then
change.
go to 16, 18, 20. This is a typical SBO. Down.
But because there is a calcified nodule as a process of flex, so during the ballooning or standing, so the major concern is the slow flow or even no flow.
So after SBO, and also we check the angiogram, there is no complication for the circumflex. So next step is very important. So for decay crush, we will use a 3.5 balloon to do the balloon crush. And also balloon size is according to the distal left main lumen diameter.
Okay. So because the image quality is not perfect, we could not see clearly how long is the protrusion of side stent into the left main.
From our side, maybe 3 millimeter, 3 to 4 millimeter protruding into the left main. Yes.
Okay.
Okay.
This is
Several
a
minutes.
main vessel balloon going to do
Yeah.
first balloon crush. Looks like
Crush.
the circumflex stent. Circumflex stent was expanded very well.
16. So 3.5. Down.
Good.
Up to 16, but we did not get fully crushed. You can see when do the balloon dilation, we inject the contrast. Actually, you can see there is a contrast slide into the circumflex, which means 3.5 balloon is not enough, is not big enough, fully crush the distal left main stent.
So do you plan
So
to use? You plan to use another large NC balloon to crush again, or just leave it?
Yeah, I fully agree with you, Prof. I will use a short balloon, which we named as a port balloon. It's domestic balloon, very short, only 6 to 8 millimeter. But I will upsize the balloon. I will use a 4 balloon to do the post crush again. Are you agree?
Okay. So I think here is the key point of a decay crush, because even they perform the balloon crush, but the balloon size is the underside for left main. So we need to use another large NC balloon to complete the crush the side stent. So even decay crush has multiple steps, but I think each step is very easy for intervention cardiologists. Professor Raboy is also the expert of decay crush. I know you have done many decay procedures. Any comments?
No, I think I've learned a lot from you. I mean, so yeah, so we have got to close the gap, and I think taking a larger balloon, crushing is the right thing to do. You always worry about dissection, the ostium left main, but as long as you have a wire there, I think you'll be all right.
Right.
Now, the proximal stent optimization makes it so easy to recross into the side branch.
So after first balloon crush using 3.5 NC balloon, so the proximal third stent looks very, very good. So now it's a POT pouch balloon. It's very short, only 6 millimeter. And this is a particular balloon designed for post dilation, for distal edge or proximal edge, because it has very short shoot.
Which balloon is this?
The pod balloon.
Yeah.
POT balloon. It's a
Any
Chinese company manufacturer. Because the shoot is very short. It's only 0.3 to 0.5 millimeter. So it's very difficult to get edge dissection.
又没信号了。
Yeah, I think this is a good position.
是啊，
Okay, very short.
撤吧。
So you say the distal balloon did not extend it to distal to the corona. That's very safe for RAD.
帮我准备一个双腔胃道管，准备好，万一要用。先准备 IVUS。 断线，是
那边网络不太行。
兄弟们，咱们照顾可以了呢，可以啊。哇，这个
Yes, we can see some is a dissection just distal to left main.
Yeah, that is dissection. Considering the 2 position is on the position, so I happy there will be safety.
How common you see these dissections while you do the main stem with the larger balloon? It's quite often, or it's very rare, or?
Yeah, actually, if not so eccentric calcification is not so often. But for this particular case, eccentric plaque, there will be cause.
Thank you.
So actually, I use a third wire to rewire the circumflex. So at this time, from the angle, I'm not sure it's from the proximal cell. So I will go to another view to check the wire is from the proximal cell access to the circumflex. It's very, very important for the decay crash. Two-step wire to the side branch should from the proximal cell. Avoid the distal cell. Otherwise, the wire will go on under the stem structure. So at this time, you can see the third wire is just overlapping with the previous jet wire in the circumflex. So from this view, from the angiogram, I think the third wire rewired from the proximal cell, but it's not enough. So I will use IVUS check the wire position. So at this time, I will insert the wire to the LED and to the pullback and to evaluate the wire position. Professor Chen, can you hear me?
Yeah, I can hear you very clearly, but I think because of the time limit, probably.
Okay.
17 minutes.
Yeah, you only have 15.
15 minutes.
5 minutes.
Okay. Okay. I try.
So you will check ours from right to left main.
Yeah. Okay.
Okay.
So Dr. Panta, please check the IVUS.
Yeah, I will pull back the IVUS. Can you see the IVUS imaging?
Not yet. Yeah, okay, now, okay.
Okay. The IVUS, this is the proximal LAD. We can see the media dissection. And here we can see the circumflex virtual in LAD.
Yeah, it's from proximal.
Yeah. We're sure it's passing through the proximal cell.
Okay. So please give me NC.
So I think rewire is a very good position. So Jun-Jie, did you remove the second wire?
Yeah, now I will remove the second wire. Prof.
Could you
The previous
switch
wire.
to angiography?
Yeah, sure.
Good.
这个事情。
What wire do you use to recross the proximal cell?
Is this BMW wire to recross this side branch?
This wire is a Sion wire.
Okay, thin wire. So then you will use 3.0 balloon in SIR and another 3.5 in RAD, right?
Yes, yes.
Can you show?
Too much.
2.5.
So RAD is 3.5.
2.7.
Can you play the image?
Okay. So considering the circumflex stent is 2.75, so I will use a 2.75 NC balloon.
Angiogram is frozen.
Yeah. Go to, okay.
Sorry. I didn't.
You can see at this time I have a resistance cross 2.75 NC balloon into circumflex. At this time I use the angle balloon technique. Please up the 3.5 balloon to 6.
Now you
can see.
Now we can now see angiography, which is frozen. Yeah, exactly. Once confirmed the rewire from proximal cell, and also if there is any resistance to pull the NC balloon into the side stent. So as Dr. Jun-Jie Zhang said, they are using balloon anchoring technique, inflate LD balloon to facilitate the pass-through of the side branch balloon.
Sure. So before do the first kissing balloon inflation, we sequential post-dilate the ostimal circumflex with high pressure.
Okay, now 18. We can see angiography very clearly. I think the NC balloon has entered into the circumflex. What's the diameter?
Yeah, with 3.75.
Okay. So
with the angle balloon technique, yeah. Then we do the first kissing.
Okay.
High pressure first.
Yeah.
How high? 16 or 18? 16.
18.
18. High enough. So, yeah, why not? Good question. Good question. Yeah. Actually, for NC balloon, there is very, very slight increase in diameter between 14 to 24.
After first kissing balloon inflation with the 3.5 and the 2.75,
now
we
I think so.
Switch to 3.5 extending.
Yeah, another very important point is that during kissing inflation, so the overlapping length of two balloons in the main vessel should be as short as possible, usually 2 to 3 millimeters, because we try to recreate a metal carina. So to avoid the extension, elongation of the carina. That's very important. So you have successfully performed the first kissing, right? So next step will be very easy for you. So what's the length of next stent?
3.5 by 29, 5-hook stent according to the IVUS evaluation. Let's go to the IO cranium.
Okay, so the first stent in AD was a 5-hook, right? Is it still 5-hook?
Yeah. Still, I use a 5-hook. Thank you.
Okay, can you tell us what are the advantages of 5-hook stent for distal left main bifurcation lesion?
So first, the high hook, actually there is a very important study compared with Zhang's V and non-inferior to this Zhang's V stent. And the first, I think the most important, just as you mentioned, for distal left main bifurcation lesions, 5-hook, the radial force is quite good. And also the stent open cell is very suitable for sideburn access. And the most important thing is for 5-hook, the post-dilation ability is quite good. Like 3.5 stent can very safely achieve to post-dilation up to 5 millimeter. So from this view, I think for this particular case, 3.5 stent crossover circumflex, and for the proximal, for the left main, we can safely use 4.5 to 5 balloon to do the post dilation.
Okay. So I highly suggest to move to aerocranial to identify the location of ostomy left main. Do you plan to cover the whole left main?
Yeah, surely, because from the IVUS imaging, the left main is diffused lesions, aerocranial. So I would like to fully cover the optimal left main, Prof. So what's
for any stent covering osseous left main, so to avoid the longitudinal compromise is very important. So you are using EBO 35 guiding catheter, it will be a little bit tough because we need to.
Okay.
Yeah, they did not use. Actually, from IVUS, I will prefer to use cutting to prepare lesion, both in RAD and circumflex. Because IVUS confirmed the calcified nodule.
Yeah.
Yeah, which is a typical sign of SAS unstable lesion. Thank you.
But he didn't opt for cutting balloons over here. And what is your have you ever used a cutting balloon into the left main also?
No, after NC balloon post dilation. And
no, they did not use.
Show,
they did not use.
Yeah.
But Jun-Jie is very strong. Jun-Jie is very strong in treating complex PCI.
Dr. Zhang, one question especially for fellows. And do you cover the left main till ostium, or we can stop in between, or it depends on the length of the main stem or the lesion? Can you give some comments, your experience?
For the left main, if the left main is longer than 15 millimeter, according to the intracorneal imaging study, actually is always diffuse lesions. From this case, from this information, for this case, I will fully cover the ostial left main, avoid the geographic miss. And also, just as Prof mentioned, at this time, I will be very cautious to avoid the guiding catheter. Cause stent distortion. Yes, please.
I feel this is a good position.
Are you happy?
Whenever we are doing this left main, up to the left main, there's always this big debate. Should you hang 1 millimeter out or should you not hang? So that is the thing, because, getting it right at the left main is always an ostial trick. So what is your take on it?
Yeah, right. I think a maximum protrusion limited to 1 millimeter is a requirement. Also, for some junior interventional cardiologists, it will be very tough. But to achieve the maximum 1 millimeter protrusion, we need multiple injection, particularly aerocranial. It's a best view. Thank you.
The left main is always at an angle, so you'll have some protrusion coming.
Yeah.
And he's put a marker wire there, if you notice, to see where the ostium is.
You hang a wire over there or something like that.
You've got a marker wire.
You put a marker wire over there.
So you can
How much is the inflation pressure?
I inflate the stent at 12 atmosphere, and then I pull back a rectal and do the post dilation with the stent balloon to 18 atmosphere. Then I will still use a 4.0 NC balloon to do the post dilation before I rewire the circumflex.
Okay. So the circumflex wire is still in position.
Yeah, I just pull the wire in the aorta. Yeah. To avoid the guiding catheter injuries ostial left main stent.
Okay.
Okay.
So I think a spider view will be much better.
Yeah, go to spider view. Thank you, Prof. Thank you, Prof, for your kind. So I put the circumflex wire into the aorta, avoiding the guiding tip injuries.
Yeah, this is
the
very
left-man
important.
stand.
Using that wire, just in the aorta to avoid the
Mark the wire,
mark wire to prevent longitudinal compromise. So this is a 4O non-compliant balloon, right?
Yeah. Yes. Up.
But the left is larger than a 4.0, wasn't it? It's close to 5.5. So why are you using 4.0 now?
Right, the vessel diameter is 5. The baseline lumen diameter is 2.5. So they use a full non-compliant balloon by high pressure. I think a stent diameter could be achieved by 4.2, something like that. I think it's big enough.
20. Down. Up again.
Yeah, I think this is a good position for distal left main.
20.
Okay, good.
Yeah.
Again, quash the side stent.
Yeah. I think at this time when I inflate balloon and I do the contrast injection, there is no contrast leaking into the distal area, so which means the stent is fully, I think it's fully conditioned.
Okay.
Dr. Zhang, Dr. Zahir, we have 7 minutes more, and then we will leave it to, if it is okay.
Okay.
Yeah, 5 to 7 minutes.
Thank you.
Please.
Okay, I will do thank you very much. I will do the final step. I will do the final rewire. Anyway, before we rewire, we do the angel again.
Okay.
Because ideally you should have 10 minutes because we started late by 10 minutes, but just to be comfortable, what best you can show to us.
Give me a new wire is damaged. At this time, we are secondary wire are still from the proximal cell. So I will still use the angel and the IVUS guidance. I think the wire tip is a little damaged. Maybe I will change a new wire. You see, C1 wire is damaged. Sorry. Please give me a new wire. See the problem. 3.0的高压和3.5的高压 final placing. And the patient is stable. Let me take a picture. At this time, I think it's from the proximal cell. What do you think? Go to the AP caudal view.
By the time Dr. Zhang is trying to recross, any panel's opinion to how many of you would do the OM also, because it's a disease in the ostial OM. Is there, would anyone leave OM and just do 2 stents?
Continuation circumflex.
Yes, just the circumflex.
Old saying, best is the enemy of good. So
you'll go for
yeah, probably, but see, my only one question is that his procedure has gone out very well. He first did the RCA, and then he proceeded. If he had not done the RCA, would he have been comfortable? Because many times in the world of economics, you'll say that this gentleman has triple vessel disease and they are bad calcified lesions. So if from a bypass graft surgery point of view, he will get these 4 grafts. But from an angioplasty point of view, then you'd say, yes, his obtuse marginal must be done also. Because from a surgical point of view, it was a target. So it has to be done. So, but should it be done in the same sitting or not? Now that becomes the question, because after such a prolonged procedure, what kind of elevations of troponins has already happened? That we don't know.
Dr. Zhang, we have two presentations ready from United States. So is it okay if we leave? We really learned a lot from this wonderful, excellent case, and very nicely done. So is it okay if we just leave in now? And congratulations for doing everything so far so good. All right. So we now disconnect and go to the other hall. We have one lunch ready for you, and another session in Sheesh Mahal 2 hall, where Dr. Rukhsana Mahan is going to start her presentation. Thank you, Dr. Zhang, and your team. Thank you very much.
Thank you. Thank you.
There is a lunchtime session next door in Sheesh Mahal 2, Go Red for Women, and it's on basically interventional cardiology and women, and Dr. Rukhsana Mehran and Dr. Mirwat Al-Asnaq from Saudi Arabia will be talking. They're excellent speakers, so I would encourage you to go there also. Thank you.
必须录，把它录完，知道。